Welcome everyone to the Lyfebulb educational series focused on inflammatory bowel disease. Today, our topic is going to focus on medication and how we treat patients with IBD. And with IBD, we mean Crohn's disease and ulcerative colitis. I'm joined here today by Dr. Joel Bauer. I'm Karin Hehenberger, and I am the CEO of Lyfebulb. And we have a fantastic panel of speakers in addition to Joel and myself. But I'm going to let Joel introduce our panel and start with the first questions. Thank you so much for joining. And as you know, this is a recorded session, so you can also listen to the recorded session afterwards.
So we have Ellen Scherl, who is the founding director of the Jill Roberts IBD Center at Weill Cornell. She's professor of medicine. We have Cohen, who's assistant professor, division of gastroenterology at Mount Sinai. And we have Tina Aswani Omprakash, who is a IBD patient advocate and a master's in public health student. So the first question, I think we'll just have it for Lewis. Are the medications for IBD the same in Crohn's disease as in ulcerative colitis, or are there differences?
So it's a pleasure to be here, first of all, and I'm always happy to sort of chat about this. And I think it's a very important question. And oftentimes it always begins when our patients sort of ask us about the differences in these diseases. And I think that, you know, ultimately the answer kind of begins, I think very broadly, we're saying that there's probably more overlap in our medications between these two diseases than there are necessarily differences. But there are some differences. I would say that in certain cases, there are certain medications that we may use more exclusively in one disease or over another. These tend to be medications that I would say don't fall into what are more of our kind of typical armamentarium. So a drug, for instance, like cyclosporin, which we use for patients who are quite sick, that might be one where we only use it exclusively in ulcerative colitis, and we tend not to use it in Crohn's. But aside from these kind of sort of outliers, the vast majority of our medications have fallen to classes, whether they be biologics like our anti-TNF drugs, tend to be used for both of them. We do see some differences, again, depending on the patient. You know, I always tell every one of my patients, every person with IBD it's like a snowflake, right? They have their own unique characteristics. So sometimes based on the location of the disease, we may also change which medications we may lean towards. But I would say that all in all, for our patients, the principles of the medications, the ones we use, you know, tend to be more similar than they are dissimilar. The final caveat I would say is insurance. So as we've gotten more and more drugs that have come to market, which has been incredible, sometimes the companies sort of pursue one indication before the other. Oftentimes the trials are being done simultaneously, but one may sort of make it to the finish line a little bit sooner. And so in those cases, sometimes patients will see, oh, we have a new drug, like for instance, upadacitinib or Rinvoq, that was just approved for ulcerative colitis. Well, the data is coming down the line for Crohn's, but those may be some nuances also that can affect what patients, maybe not what drugs are effective for the patients, but what drugs patients may have more easy access to.
So here's a question that was pre-submitted. I think I'll let Ellen handle this. I was sort of surprised at this, but I think it's actually a good question. When are medications utilized for IBD, Ellen?
So the medications that are utilized for moderate to severe Crohn's disease and ulcerative colitis are what we now consider to be disease-modifying medications. So the anti-TNF therapies, the anti-IL-12/23s, the anti-cytokine, the anti-inflammatory protein actually have the ability to change the ongoing inflammation and progression of the disease. Those are for moderate to severe Crohn's and also for moderate to severe ulcerative colitis. Different molecular targets, such as the JAK inhibitors, the JAK class, selective and non-selective, ozanimod, which will also be approved for Crohn's as well, sort of sphingosine receptor antagonists that trap the lymphocytes in the lymph nodes and don't allow them to come to the intestine where they pour out their inflammatory cytokines and cause inflammation. But the important thing is that not every patient has moderate to severe Crohn's or ulcerative colitis. And I think we've learned from pivotal trials, namely the SONIC trial, that if patients have moderate to severe symptoms, if these symptoms are not due to inflammation and we use anti-inflammatory disease-modifying medications, we're wasting the medications. So I think it's important to recognize whether the patients have symptoms that are in fact inflammatory and related to moderate to severe disease, in which case we want early intervention, less steroids, less mesalamines, less ineffective medications, and we want to go to the newer medications that are much more effective. On the other hand, if their symptoms are due to overlap with irritable bowel syndrome, with bile salt diarrhea, with lactose intolerance, with pancreatitis, with food intolerances, then we want to address those as well. So I hope that answers the question.
So that's the ultimate scenario, I guess, when we can look at the symptomatology and we can look at the laboratory results and we can try to match the right treatment with the right patient. And Tina, is that the reality, or do you see in your patient community and also in your own experience how patients may need to follow formularies and need to start on a maybe less potent drug and fail before you get to the next?
You know, that's a great question, Karin. And I think the reason why I think this question is very important, going back to what Dr. Bauer is talking about, is there's a lot of patients that often reach out to me, and I myself went through this, that have trouble accepting medication. I hear a lot from various racial and ethnic communities who have trouble accepting that this is beyond a dietary condition. This is beyond a diet and lifestyle condition. So one of the things that I often tell patients and that I've had to learn and accept myself is that we do need oftentimes proactive medication and proactive understanding of this disease. We do need to tease it apart, like Dr. Scherl said, from IBS, from bile acid diarrhea and other conditions, to make sure that we're treating to a target. And I think it's very, very important for patients to understand why certain medications might be recommended aggressively at times, depending on the presentation of their disease, as Dr. Cohen was sort of talking about with regards to the medications involved in Crohn's and ulcerative colitis. I think a lot of young patients really struggle with the idea of being on a biologic at a young age. And I think that's something that we have to continue to work on in terms of understanding and in terms of education for patients to realize, look, your doctor knows best. They're understanding the presentation of your disease via colonoscopy and imaging, et cetera. And if they think you need this, it's for good reason.
I got the impression from our last session with the pediatric gastroenterologist that there wasn't a big problem anymore with putting younger patients on biologics. What do you think about that, Louis? I know you don't treat young children, but is that sort of passe, that thinking? Because I know that was very common about 5 to 10 years ago.
Yeah, I mean, I think what Tina said is still very applicable, which is that we oftentimes still run into a lot of discrepancies, I would say, in sort of patient literacy and healthcare literacy specifically is what I mean. And I think so sometimes, yes, I think the vast majority of our patients understand the role of these and are a bit more accepting. I still find that there's a huge role for education. I think luckily for us, we get to say, well, a lot of these drugs, especially the biologics, where I think there was a lot of concern starting young patients on these a long time ago. We've now accumulated 20, 30 years of evidence of this. Mm-hmm. So, I think a lot of it comes down to the foundation of explaining the design of these drugs. I think they can feel scary. I try to avoid those types of terms or even the word aggressive sometimes, because I do think, to echo what people say, it's about finding the right fit. And I think especially in the pediatric populations, the data has been so clear that getting the right patient on the right drug at the right time helps these children to meet all the milestones they need to in terms of social development, in terms of growth. And so I do think that there has been a lot more adoption and a lot more understanding, and thankfully it's driven by good data that tells us it's safe. But I still think we have a long way to go to help educate everybody to understand the role of these drugs at different times.
But I still think that I haven't heard a real answer to my question, which is in other disease areas, and I'm very familiar with diabetes and other areas, autoimmune disease, there's a certain pathway. You can't just put a patient on the most I call it aggressive, and you don't want to use that term, but maybe the most novel drug, because you first have to fail on other drugs. Is that not the case in IBD?
So
I wanted to
would say-
just break in here a second because I was just about to ask that question, and I guess I could ask Dr. Scherl. The whole concept of top down and step up.
Sorry, Joel, are you asking the same question that I just
The
asked?
same more or less question. but
Okay, so I'm not
it
sure
is
why you're doing that.
in the
I
last-
just asked the question.
Yeah, but I think it's
that we
important
would
that
always
Joel
start with
is
a-
underscoring
Okay,
the concept. So I'm going to answer both of your questions about algorithmic
Go ahead,
medicine.
you know what we're
Okay.
talking.
Yeah,
Okay.
so exactly. So the algorithms for medicine, the old algorithm was,
Right.
the old strategy was you had to have failed the conventional therapies of steroids, mesalamines, therapies that are completely ineffective in maintaining remission and changing the natural history of the disease. You had to fail that first. And then you could get these more effective
right.
medications. The newer strategy is to use the more effective therapies earlier on, first line therapy.
That's what I wanted to
earlier on.
hear.
And
Yep.
that's an algorithm. It's an algorithm. But what we are saying, whether it's the AGA, the American Gastroenterology Association, the American College of Gastro, whether it's the European societies or the Crohn's and Colitis Foundation, whatever the algorithm is, this is algorithmic medicine. Patients don't necessarily want to fit into the algorithm. Even if they do, they will say, well, you know something, I may have moderate to severe disease, but I don't want to take these medications. And so it's very important that we do what I think you're getting at, which is we have to listen to each individual patient.
Right.
We have to find out what their support system is. And there are times when we will say, look, there is no other way out. You're going to end up with surgery if you don't do this. But before we do that, we really have to find out what the barriers to their understanding is. And we have to listen. Sometimes they really sound like they have moderate to severe disease, but maybe it was an acute infection. And then they're seeing doctors who say, let's put you on a biologic first. And they say, we want another opinion. Maybe the other opinion is, let's wait and see. Let's do some lifestyle modification, nutrition, if we think it's appropriate. And if not, you know, it doesn't work, then we go to the biologic. But you have to try to meet the patient and the family and the support system halfway. And literacy is another issue. Diversity is another issue. A lot of factors go into this.
But I do think there is an important point, if I heard sort of this echoed in that question a little bit, is the idea of the algorithm. And what we're referring to is actually an incredibly rough algorithm. You know, at this point, that the idea of the steroids and mesalamine is sort of 20 years out of date. And we now have an army of biologics and various small molecule drugs. And we do not have great data to help guide us as to which ones of these we should start first. A lot of it, as Ellen referred to, is nuanced, right? It's a conversation between the patient and the physician and the expertise of that particular physician in terms of how they think about positioning these drugs. But we don't have the studies we need to actually answer those questions. Part of that, I think, is driven by the lack of motivation, which is a nice way of saying funding, to be able to do these head-to-head trials. Second thing I think, and I hate having this conversation when I talk to my patients about how I want to position the medication from them, but I legitimately say, you know what, at the end of the day, insurance is going to have a say. And in some cases we have wiggle room, but in other cases we don't. You know, if our insurance company says we are only going to do this biologic, show me the evidence. Well, you know what, sometimes I got to raise my hand and say, I don't have it, even though my clinical expertise and maybe what we see in terms of how we compare trials may suggest one therapy is better than another. We have a lot of ways to go.
Right. I think that I still am in the fighting the insurance mode and insurance teams and pharmacy teams, so that if there is a drug that's less immunogenic, that we can use as first line, and then we use another drug and it works as though it were first line. I'd like to use those less immunogenic biologics, and now the small molecules, I'd like to use those earlier than the more immunogenic anti-TNF therapies.
So
I also think,
Dr. Scherl, can you explain what immunogenic is to our audience?
yes. So some of the drugs that the original drugs that Joel Bauer was talking about, the anti-TNF therapy like infliximab, Remicade, adalimumab, Humira, and the biosimilars that go along with that, that class of drugs are antibodies to these inflammatory proteins, but they are foreign antibodies, and antibodies are also proteins, and your body can make antibodies to those antibodies, to the drug antibody, and then you lose response. There are newer versions of these drugs like anti-IL-12/23 or anti-23 that are much less immunogenic. And then these small molecules like the JAK inhibitors, upadacitinib, ozanimod, do not form antibodies at all. So you can stop and start these less immunogenic drugs without losing efficacy. And so my feeling is that those are the drugs that should be used first. And in all the controlled trials, they actually show that if you use an anti-TNF first, and then you use these less immunogenic or small molecules, the patients don't do as well as if you use the less immunogenic molecules first and the small molecules first. And then you use anti-TNF, the anti-TNF work as though you never used a drug before. So we have to recognize that a little bit. And also to Dr. Cohen's point, steroids have been around since 1950, but the sad thing is that we're still using them like 1950. And even though we talk about algorithmic medicine and trying to figure out which one is the best, the fact is that more than 90% of patients with moderate to severe ulcerative colitis or Crohn's disease are on ineffective medicines, steroids, 1950s, and mesalamine, 1960s, 70s medications. And that means that the patients are being treated ineffectively. The disease is progressing. We're doing nothing to reverse that. You know, I'm very impressed with Corey Siegel's work, the IBD Chorus, which is QORUS, which is quality outcomes. Again, underscoring the importance of understanding whether the symptoms are driven by inflammation or not. It's a questionnaire that really invites the patient to work off a playbook, if you will.
So a patient out in the country, I mean, Tina, you should be, but the patient out in the country, not access to these nice institutions that you represent. What should they do? You know, how do they get access to these new drugs versus being treated with drugs from the 50s?
Yeah, that's a great question, Karin. You know, I'm fortunate enough to be in New York and to have access to some of these exemplary centers. But I will say I often do hear from patients who are out in, you know, places like Oklahoma or Nebraska and places where they don't have as great of access, and they will be driving 4 or 5 hours sometimes, or flying for some of their care. I often do tell them, you know, there are IBD centers within several hours of you, and to make sure you consider that. Because here's the reality of it. When I was in New Jersey and when I was getting care in New Jersey, many of them did not know how to prescribe infliximab or how to even prescribe ustekinumab. So these were challenges that I faced, you know, just living 50 miles away from New York City. I cannot imagine what it's like, you know, living in places where there is less access, but that is something that I always recommend is consider an IBD center. Nowadays, given the pandemic, people do have more access to virtual. I realize that that is also governed by insurance, but you know, there are ways to get your care and to coordinate some of that care with a local gastroenterologist as well.
So let's say you're starting on one of the medications that's less immunogenic. Lewis, how do you decide when it's not working? First of all, is there a time period that it takes to work? Is there a startup time, or should they start immediately?
So it's a great question. I think
they start working immediately?
Yeah. So I think it would sort of, I'd want to bring a couple points, but I think I'm going to sort of echo what you heard Dr. Scherl saying earlier, which is first, you know, when we start these medications for a lot of our patients, I think the important thing to understand is that, you know, we don't necessarily have a guarantee, right? That there's an expectation about if these medications are working, when should they start to work? But it doesn't necessarily mean it's going to be for everybody. So that it's important to have that feedback with the physician as you're kind of going through those initial phases, and that those expectations are set early in that meeting, right? If I'm starting this drug, when should I start to feel better by? For some of our medications, that could be months. For some of our medications, even some of these newer ones like upadacitinib or Invoke, that can be even in days. And so these are important expectations to set. But the other thing, which I think is critical, is this idea of the interplay between inflammation and bowel healing and the function of the bowel, which is what we keep talking about over and over again. Our medications that target the immune system target the inflammation. They're not necessarily targeting other functions of the bowel, which to a patient can feel identical, right? The diarrhea can be due to inflammation of the bowel lining and lack of absorption of water, It can also be due to damage that's happened to the muscles and the nerves of the bowel that lead the bowel to move more quickly. At the end of the day, a patient's still having diarrhea, but how we treat it, in one case with medications that are targeting the immune system, in the other case with medications that target the muscles and the nerves. And as a patient goes through this therapy, we may see this, right? Someone's feeling better, and then there's sort of a lull, and I'm not getting back to where I feel like I was. And so then that comes down to how we evaluate. And this is with all of the non-invasive measures that we've talked about. There are blood tests, there are fecal tests that help us understand, are we quieting that inflammation? But at the end of the day, I still believe that the gold standard of having an endoscopy, which includes obviously an upper and a lower endoscopy, to sort of see that healing of the inflammation is still critical. So, each of our medications will have different time points. It's important to understand that when working with the physician, but it's also important to understand as a patient that not all that is diarrhea or belly pain is always going to be inflammation, and sort of understanding those transitions will help to guide us as we know that this medication is either working or we need to supplement it potentially with other medications to focus on the bowel function.
Okay, so this leads to the idea of strictures in Crohn's disease, okay, even though you didn't mention that. So you're not going to be able to treat a fibrotic stricture with a medication. So Ellen, how do you determine whether a stricture of the terminal ileum, the last part of the small intestine, is a fibrotic stricture from years of disease, or whether it's inflammatory and therefore might respond to medication? Whereas if it's fibrotic, your answer is really surgery.
So
How do you make that determination?
simply put, when there's a fibrotic stricture with dilation of the bowel, so nothing, it's like a bottleneck, nothing gets through, and the patient is nauseated, vomiting, they're symptomatic, they're losing weight, then we know through the imaging that this is scar tissue, and through the history that this is obstruction, and that the patient likely needs a resection. And sometimes the resection is not a failure of therapy, it is the appropriate therapy. Now, how long does it take for strictures to form? There are two timelines. One is how quickly the medications work that I want to come back to, but the other is how quickly does the disease progress? And we think that it takes about 10 years from an inflammatory behavioral pattern to stricturing and then to fistulizing, which are these tunnels that burrow through the wall of the bowel around a stricture, or just burrow through the bowel wall to begin with and cause all sorts of inflammatory, infectious complications. So if it takes 10 years from inflammatory to stricturing disease, we want to use that playbook like the IBD chorus to make sure that we're following our patients. We want to look at the fecal calprotectin, as Dr. Cohen says. We want to make sure that we're understanding where those symptoms are coming from. And I like to see my patients every 3 to 4 months, even when they think they're doing well, so that we can prevent the progression and have this conversation of when to intervene with biologic therapy, when it's appropriate. We can have this therapy over time, this discussion. It doesn't have to all be make a decision today. Okay, so that's one timeline, the timeline of the disease progression without any intervention. The other, as Lewis said, is if you look at the anti-TNF therapy, the average time to onset is 2 weeks. 80% of patients who respond will respond within 2 weeks. We need to have realistic timelines. With the ustekinumab, maybe 2 to 3 months, 2 to 4 months, with a glimmer that something is happening at 3 weeks. With vedolizumab, it's a little bit longer. For Crohn's, a little bit shorter. For ulcerative colitis, but the point is we're talking about months. So we want to talk about steroids as bridge to allow these therapies to work. But realistic expectations that the patient needs to know what the onset of the disease is, the onset of medication working, and then what happens in terms of maintenance and reversing disease. So it's a big discussion that has to play out over time, always listening to what the patient's concerns are, because the minute we don't do that, we lose our communication skills.
I think that's so, sorry, just one intervention. I think that's so important what you just said, but it also shows the importance of communication from the physician, right? The two of you or the three of you here are excellent communicators. That's why you're in a seminar as well, right? But in speaking to a patient about these timelines, and if you're in a center where there is no IBD expert, how do you know that it takes months until? So Tina, in your experience in speaking to so many patients in your community, I mean, do you see these kind of this patient stopping therapy that hasn't yet functioned for them, but it actually just is part of the timeline. They just haven't been explained to, or they haven't understood what the mechanism of action is.
Yeah, I hear this a lot, especially outside of New York. I'll be very honest with you. And I think there are not just fears around therapies, but fears around long-term therapies. The thing that I often explain to patients is if this is a chronic illness, you're likely going to need medication chronically. And so that's, I will say over and over again, Karin, that acceptance is key. And going back to what Dr. Scherl, Dr. Cohen are talking about this being a conversation over time, it takes time to accept the chronicity of a condition, especially when you're diagnosed as young as some of us are. And I can't even imagine what it's like as a pediatric patient to be diagnosed, but it is challenging even for parents that I speak to accept the chronicity of this illness. And I think as it's being said over and over again, that this is a conversation over time. There are a lot of patients who do drop their medications. I've spoken to patients who were pediatric patients who would stop their azathioprine or stop their mesalamine. I think especially the oral pills, that can happen, but even with some of these injectables, it often does happen. A lot of us have a fear or just a hesitation to inject ourselves. And I think these are very real challenges that patients face that they often struggle to even mention to their physicians. But, physicians can pick up on this if the patient, isn't doing as well, or their numbers or their stool isn't coming back, the same as it was. So there is non-compliance in our community. I will say I have been through non-compliance based on, sort of this frowning upon taking Western medicine in my community and in my South Asian community. It happens a lot in my community where patients and parents often feel like, why do we have to take this forever? Why can't we be cured? It's not that simple. And I
What
think
do you want to hear from your physician?
what would I want to hear from my physician?
I'd like actually the physicians on the panel to talk about it briefly.
Yeah, sure.
When there is going to be a change that the physician, whether it's going to be another medication or whether it's going to be something drastic, like you've been through 5 medications, you need surgery. How do you want that presented to you? Directly? Do you want it gently? Obviously it depends on the patient and the doctor, but at some point the doctor who has the knowledge has to tell you, let's take the most drastic approach. You've been on 4 or 5 medications, you now have a stricture in the terminal ileum, and you probably would do best to have a resection of that segment. But how do you want to hear that from your doctor?
I think from a patient perspective, and I've obviously been told this many, many times, having had as many surgeries as I've had. So I think I'm kind of used to it now. But initially, there's a lot of shock value. I think that this is, again, a gradual discussion over time. If a patient has tried one medication for moderate to severe Crohn's or UC, and that patient is not showing signs of doing well, even on that first medication, I think it needs to be brought up early on. The shock value of having to get an ostomy or a J pouch or having a resection is real. And I wish that I was told, even when I was failing things like mesalamine, and I hate to use the word failure because it's not a failure of the patient, it's a failure of the drug. Even when mesalamine wasn't working for me, I wish my physicians would have brought up at that time, we will work towards this algorithm, so to speak. But, we want to, make sure we bring up that there is always surgery as an option, and have that as a gradual conversation rather than shock value. And I think the same goes for strictures and fistulizing disease in Crohn's disease specifically. I remember the shock value of having my first rectovaginal fistula. It really beats down on you. And I think it's very, very important for patients to realize that this is a complication that can occur. Even though this disease has existed in my family, realizing that I have a rectovaginal abscess and potentially a fistula, it bowled me over. And I think we need to mention complications. We need to mention, other medications, surgery, without scaring the patient, but also letting them know, hey, this is a possibility, so that patients can start working on accepting things.
Joel, you and I have talked about early introduction of the surgeon to the family and the dynamic that's going on, just so that they understand not necessarily that surgery is now, but they understand what the surgical options are. I also think taking a good nutritional history, especially for the stricture that you keep on bringing up, a patient who doesn't eat all day because of loud bowel sounds comes home at night and starts eating a big dinner and then is awakened in the middle of the night because they can't process it. If you can get that history and modify their diet throughout the day, then it becomes less worrisome. Ultimately, they may still have surgery, but the point is you bring the surgeon in, you bring the nutrition team in, you really try to tease it out before, and so that the patient, as Tina's saying, it's less of a shock value, and surgery should be part of the algorithm. Early introduction. No, I'm going to introduce you to the surgeon, not for surgery, but just so that you understand what the options are and what we're concerned about.
Yeah, I always found that very helpful, as opposed to the surgeon bolting in the room in his scrub suit and saying you need surgery now. So I think that's very important. I think we've covered most of the. Tell me a little bit about the side effects of the medications. Do you discuss them with the patients?
Yeah, we always talk about efficacy, which we've talked a lot about here, and then we talk about safety issues, severe immune suppression, the FDA black box around certain medications like the anti-TNF, like the JAK inhibitors, because they suppress the immune system. Not so, that does not exist for some of the newer drugs like ozanimod or ustekinumab or the anti-IL-23s that we're going to see. But yeah, we talk about infection risk. We talk about long-term immune suppression in terms of lymphoma and cancer risk. Those are the issues. Does the patient, is they at risk for herpes zoster and get the Shingrix? We're now in a viral era. So we want to make sure that we know that the patient's immune system and nutritional status, their vitamin levels, are as optimized as possible. So there are a lot of things going on. The stress factor, the nutrition factor, the family dynamics, all this really comes into play in terms of adverse events as well.
Great. Well, I think that
I have no other questions either, and I think you covered all of the pre-submitted questions, so I thought we can move on unless someone has anything very important to say.
I just wanted to say one thing, and I agree with Dr. Scherl. I think patients are often concerned about side effects, and it is something that's good to talk about. But I think what needs to be emphasized, and I wish 10 years ago or 15 years ago this was emphasized, so I feel like I could have made a better decision, that quality of life that you can get outweighs oftentimes side effects. We can deal with side effects, we can work through them, we will inform you of side effects, but we need to make sure that this disease does not result in poor quality of life or disability. And I really wish that things like that were said to me, because a lot of times we patients and some caregivers will try to sort of emphasize side effects over really how much these medications can do for us in terms of turning our lives around.
But Tina, I think that speaks to the definition of inflammation. So the disease has its timeline and the medications have their timeline. And what I think patients need to understand is what inflammation looks like, right? We all recognize it when you have a scrape or a vaccination. It's raised, it's red, it's inflamed. But we also know sunburns do that. This is like a sunburn on the inside. And when inflammation goes on, the wound that doesn't heal, then inflammation leads to loss of function. So in the joints, you can't walk. In the gut, the loss of function is you can't absorb your food, you're vomiting, you're fistulizing, you're bypassing the absorption of vitamins. So people just need to understand what inflammation looks like. We all recognize it when we see it. This is inflammation we can't see. And I think that it's something that we need to really remind our patients of, because otherwise it's sort of like inflammation is a state of being. It's something abstract. It's actually not that abstract. And that's what we're talking about how to get patients from different cultures, different ages, different support systems, different literacy to understand what's really going on. I think it would be a big step in the right direction.
It seems to me that the chronic and progressive nature of the disease, when it's uncontrolled and when it's unmedicated, is maybe something that patients are not always acknowledging.
Yeah.
And it's a natural human reaction to push that away, like in most chronic disease. But it is something that the sooner you realize it, the better you can treat your disease. Well, thank you so much. Really appreciate this. As Tina said, we need to make these longer. There's much more that we could talk about, but I really appreciate Dr. Cohen, Dr. Scherl, and Tina, of course. And our fearless leader has left the building, but we thank him anyway.
Joe
Dr.
Bauer.
Bauer.
Okay.
Thank you, Karin. And I just want to say
Yeah.
special thank you to Dr. Cohen, Dr. Scherl for joining. And please do share, this talk widely. I would like to share this as widely as possible because I think patients really, really need to hear this.
Can we have the link? And also we should talk
Absolutely.
about defining inflammation better.
Absolutely. I think that's a good project. That's a great project with patient reported or patient.
yeah.
Thank you so much.
Okay.
Bye-bye
Thank
now.
you. A pleasure meeting
Bye.
everybody.
Bye.
Bye.